and welcome back to Psychedelics Today. I'm Chris Koddermann, and today I have the pleasure of speaking with Dr. Jerry Rosenbaum and Dr. Sharmin Ghaznavi of the Center for the Neuroscience of Psychedelics at Massachusetts General Hospital, where they serve respectively as founding director and associate director. Dr. Rosenbaum has a long and distinguished career and is recognized as one of the world's foremost authorities on mood and anxiety disorders. In addition to his role as the Stanley Cobb Professor of Psychiatry at Harvard Medical School, Dr. Rosenbaum served as the Chief of Psychiatry at Massachusetts General Hospital for 20 years until transitioning into the role of Psychiatrist and Chief Emeritus in 2019. Under his stewardship, MGH's Psychiatry Department was ranked by U.S. News and World Report as number one in the United States in 2019 and for 20 of the 24 prior years. Dr. Rosenbaum is also currently serving as the Director Emeritus of MGH's Center for Anxiety and Traumatic Stress Disorders. A recipient of numerous awards and accolades and author of over 400 articles and 12 books, Dr. Rosenbaum is also the co-founder of 3 drug development companies, namely Sensorium Therapeutics, Entheos Labs, and Psi Therapeutics. Dr. Sharmin Ghaznavi, in addition to being the Associate Director of the Center for the Neuroscience of Psychedelics, is also the Center's Director of Cognitive Neuroscience. Dr. Ghaznavi also serves as a psychiatrist at the Doughton Family Center for Bipolar Treatment Innovation and as an instructor at Harvard Medical School. Her research interests include the neural correlates of rumination, self-reported processing, and other cognitive processes underlying mental illness. Dr. Ghaznavi received her undergraduate degrees in biology and brain and cognitive sciences and philosophy from the Massachusetts Institute of Technology. She obtained her medical degree and Ph.D. in neuroscience from Yale University and completed a residency in adult psychiatry at Mass General McLean Psychiatry Residency Program. As you'll hear, we cover a wide range of topics, including Dr. Ghaznavi's ongoing study of psilocybin and rumination as a transdiagnostic phenomenon in psychiatric disorders and its relation to salience processing, gaps in the understanding of the role of the default mode network as a driver of therapeutic benefits, and how the center is using neuroimaging to further explore this question, competing models of how psychedelics work from a therapeutic perspective, and the false dichotomy of choosing between these, the use of advanced neuroimaging techniques, including fMRI hyperscanning as a way to study patient-therapist interaction, opportunities to bring a precision medicine approach to psychedelic research, including through the use of stem cells to create neural networks and organize or mini brains to explore the effects of psychedelics in the lab, the work of Stephen Haggerty to explore the potential of largely unstudied psychoactive plants, the recent FDA advisory committee hearings and vote on MDMA for Ph.D., and other topics. I hope you enjoyed the conversation as much as I did. And now I bring you Doctors Jerry Rosenbaum and Sharmin Ghaznavi. Doctors Ghaznavi and Rosenbaum, welcome to Psychedelics Today. Thanks for being with me. Been looking forward to this conversation.
Thank you for having us.
I'll have provided a brief overview of your respective bios in the intro, but perhaps you could each just briefly touch upon your areas of focus and interest in addition to the work that you're doing currently at the Center for the Neuroscience of Psychedelics. Dr. Ghaznavi, maybe we can start with you.
Sure. So in addition to my work at the Center for the Neuroscience of Psychedelics, I'm a psychiatrist who specializes in the treatment of bipolar disorder, and particularly treatment-resistant bipolar disorder. That said, I practice broadly and take care of patients from, a host of diagnostic categories.
That's not, an interest in bipolar disorder is not necessarily a natural fit for psychedelics, given until I guess quite recently there hasn't been an opportunity to study the use of psychedelics for treating bipolar disorder. I guess Shepard Pratt published something in late last year, and I think Josh Woolley is doing some research at UCSF as well.
To date, bipolar disorder is usually an exclusion criterion for studies with psychedelics. That said, it seems like there might be a role for it in type 2 bipolar disorder based on Scott Aronson's data out of Shepard Pratt. But I think, we'll have to see. For right now, I'm definitely telling my patients to steer clear, at least the patients with bipolar disorder.
And there's been no work on type 1 at this point, right? The more severe bipolar disorder?
No.
Okay. Dr. Rosenbaum?
So as of yesterday, I'm officially a half centenarian at Mass General, just completed my 50th year there. So I'm
Congratulations.
I'm what's called an elder in the field. I came to Mass General in '74 as a resident, been there ever since, was chief of the department for about 20 years, stepped down in 2019. My focus was generally on psychopharmacology, mood and anxiety disorders, treatment-resistant conditions, which led me to team up with Sharmin. We had a common interest in trying to understand rumination as a driving factor for a lot of distress and burden across psychiatric disorders. And that led us into looking at psychedelics. After I stepped down in 2019, although we had been talking about it for some time before, we pulled together a bunch of colleagues who were scientists and formed the Center for the Neuroscience of Psychedelics, more to try to understand what they were doing in the brain and potentially to develop novel treatments based on that understanding.
Yeah, I want to return to that topic of rumination, because I'm aware that it was a sort of a driver for you in terms of the interest in looking at psychedelics. Before we get to that, maybe Dr. Rosenbaum, you could give a little bit of an overview of MGH. I think for listeners outside of the U.S. In particular, they may not be particularly familiar with MSG's role in the Boston biotech ecosystem. As I understand it, it's the U.S.'s largest research institution.
Yeah, you think of it, it's called Mass General Hospital, so you think of it as a hospital, which it is. I mean, job one is taking care of patients with state-of-the-art treatments, but it's a very large institution, now part of a hospital network called Mass General Brigham, along with the Brigham Women's Hospital and other hospitals. But it's a large hospital, 31,000 employees, but what's unique about it is the nation's largest hospital-based research institute, with something approaching $1.7 billion a year of funded research in the institution, cutting-edge research in cancer, heart disease, neuroscience, on and on. So it's a unique institution, a true bench-to-bedside and bedside-to-bench place where clinicians are happy to deliver the best care, but are always aware that we need more and better. And so fully 1,000 or so of our clinicians are also principal investigators on research projects related to their areas of interest. So it's a unique institution. I think it's iconic, and I think it's important to the future of humanity because of what it does there.
It's got to allow you to bring a unique set of tools to addressing psychiatric disorders and looking at psychedelics in a way that other institutions would simply not be able to, right?
Yeah, I mean, when Sharmin and I declared ourselves the Center for the Neuroscience of Psychedelics, and the call went out, some of the world's best scientists joined the team. For example, Bruce Rosen, who runs the Martino Center for Neuroimaging.
Yeah.
His team invented fMRI and built the connectome and PET MRI and really all the systems that define modern neuroimaging. It turns out there were a number of really senior scientists who had harbored longstanding interests in this area and were keen to join the effort.
Excellent. Well, I mean, it's not surprising that an institution of this size and breadth and scope would look at psychedelics. But as you mentioned, it was really rumination that drove the initial foray into that. Can you, Dr. Ghaznavi, talk a little bit about the role rumination plays in various psychiatric disorders as a common phenomenon and a driver of the disease course, and what we understand about it, and why it appears to be so common to so many particular psychiatric illnesses?
Yeah, sure. So, rumination for the longest time has been studied mainly in depression. And, the formal definition is that it's self-focused thought that's repetitive and negative and critical. And I started off in graduate school looking at it in terms of depressed populations and dysphoric populations. Got to residency and noticed that all my patients ruminated, whether they had depression or bipolar disorder or PTSD or even, schizophrenia. And In some ways, that's not that surprising, right? Our concept of self is so central to who we are and how we go about in the world. And when someone has a psychiatric diagnosis, they have to make sense of who they are in the context of their illness, whether it's being within an episode or recovery from it or learning to manage life with it. Unfortunately, it often takes this critical form for folks because they wonder about how they contributed to their illness or how they might have brought it out. And so it really, I think there was a growing awareness that it's really transdiagnostic because it's very fundamental to who we are. And the reality is most of us self-reflect and benefit from it, right? Like if a situation goes wrong, we look back and we say, okay, what could have gone better? What could I have done better? And so there's something, self-reflection can be really positive, but it seems to really go awry, right? In patient populations. And it becomes this sort of like self-perpetuating negative process that makes people worse in terms of their illness and also puts them at risk for relapse in the case of like episodic illness, like, major depression or bipolar disorder. And so it's not that surprising that it's transdiagnostic. I think it's something that people struggle with even when they're otherwise relatively well, which means that it's a pain point for people. And there's a potential role there for prevention of episodes and for better, for more general wellness, in addition to better understanding its role in when the disorder is active.
And so it really, this ability to break out a negative loop that maybe a normal, healthy subject, when they're self-reflecting, when the default mode network's activated, they may self-reflect and there may be negative elements to that, but they're able to move beyond that in a way that patients who are suffering from psychiatric disorders aren't, right? Is that right? It's the loop sort of.
Yeah, we can pull ourselves out, right? Yeah. If it starts to seem non-productive or we're not feeling so good, we can pull ourselves out of it in a way that patients really struggle to pull themselves out.
And how does it relate to like salience processing, which I understand is also common to certain psychiatric disorders like depression or OCD or PTSD, where there's some dysfunction in the salience network for patients who are suffering from those particular illnesses?
Right.
Are they related?
Yeah. So, putting on my neuroscientist hat, right? So often, the default mode network is, active when we direct attention inwards, right? And on the self. And so it's not, it's related to self-related processing. It's not surprising that it's related to, that it underlies rumination because that's self-focused and internally focused attention. The salience network is really about directing attention externally to external stimuli in the world, like as we go about walking and see the environment and so on. What we do know is that when the default mode network is active, the salience network tends to not be as active, right? And actually what happens in healthy people is when they're asked to, attend to stimuli outside of themselves, external stimuli, whether that's pictures or what have you, the salience network comes online in a way that's a little bit more difficult for patients with depression or somebody who's struggling with rumination.
So it's an ability to switch.
And so this ability to switch, exactly. And so then we get into other complex dynamics of, like the central executive network coming in and potentially inhibiting default mode network activity. And so, part of what we need to understand is why is it, what can make it easier to switch? How can we make it so that people are able to attend in the world? But also, it turns out that focusing on the environment actually helps with rumination. So, there's walks and, there's this great article where they had folks go walk in nature versus like city environments. And that actually helped them clinically. We don't have a lot in our armamentarium that helps. But, I've literally walked patients through saying, okay, right now in this moment, can you find me something in this room, a picture that you can focus on? Tell me about the colors. Tell me about and it kind of helps extract them from the loop a little bit. And I think that what's going on there in terms of the neuroscience is that the salience network is being pushed out
online.
Default mode network. But that's a hypothesis. We haven't actually tested that. But there's something about this balance of attending internally and externally that is disrupted when folks are ruminating or struggling with rumination, that both exacerbates their illness, but also kind of makes it less possible for them to solve problems and to actually move forward and make progress.
Super interesting. So that, there's been a lot of focus, particularly on the role of the default mode network in terms of the therapeutic benefit of psychedelics. Dr. Rosenbaum, is it correct to say theoretically it's possible that it's not the default mode network per se, but the subregions or the neurocorrelates within the default mode network that are responsible for ruminatory thought that are really the drivers here? That people are looking at too big of a geography, and we really need to focus on a more narrow geography in terms of the benefits.
Yeah, I mean, that the notion is sort of correlative, meaning that there's observations that under the influence of psychedelics, you saw changes in connectivity. And so a hypothesis was generated that, decrease in connectivity in the network might have underlie some of the therapeutic benefit, and maybe explain some of the phenomenology of an entheogenic trip like ego dissolution and so forth. But as far as, what makes these substances healing, those kinds of observations of what's happening, before or after are really just hypothesis generating it. And there's certainly, and Sharmin can speak to this better than I, that certainly those who criticize that oversimplified notion that it's just, the fragmenting of the default mode network that leads to any kind of therapeutic outcome, and that other regions of the brain that may be more important. But I'll let Sharmin speak to that. She's the neuroscientist.
I mean, it's interesting actually, because the picture, the data in terms of psychedelics and the default mode network, it's not totally straightforward. So it depends on when you look, right? So oftentimes people are saying, oh, the effect of psychedelics on the brain, but the effect of psychedelics on the brain when, right? So is it the day of? Is it the day after? Is it, in the weeks after? And I think the data, the preclinical data, speaking to plasticity, really, sort of emphasizes the importance of the time period that you're looking at the brain and what might be going on. And so even with regards to the data that exists, one day after there's decreased default mode network activity, but then later there's increased default mode network activity from the same research group, right? And so what's been proposed is that maybe things break down, and so you get less early, and then later, more of it comes together. But I think that there's a lot of missing information to be able to tell a coherent story about what is actually happening in terms of the networks over time that leads to a therapeutic benefit.
And an enduring one, right?
And enduring one, right. I think I believe we're, the study that I'm leading is the first one where patients we scanned the day of psilocybin administration. And so that's a complete unknown in some regards. And then looking at it at multiple time points to really answer that question of what is happening in the brain over time, what's happening between networks, and how is that changing how they process information about themselves and about objects or information in the world.
And so which study is this you're referring to?
So it was basically what started our center, which is a study looking at psilocybin, the effects of psilocybin on neural correlates of rumination and self-related processing.
Okay, so I thought that had been withdrawn because you had difficulty recruiting but you're kicking that off again now, are you?
Yeah, so we initially, the indication was we were going to look at patients with treatment-resistant depression, but we screened, I think, over 700 people, and they just didn't meet the inclusion-exclusion criteria. And so we went back to the FDA and we applied for a new IND to just look at it in folks with depression. So lowering the inclusion-exclusion criteria, and based on the screening we've done, we really think this shouldn't present a problem for recruiting.
And so you're going to, if I remember correctly, at least for the original study, you're going to do neuroimaging before, during, and after. Is that right?
That's correct. So we'll be doing it at baseline about a week before the psilocybin administration, the day of the psilocybin administration, and again at 3 weeks and 12 weeks.
So you'll get a much more complete picture. In terms of the mechanisms of action and what's going on here, obviously a major thrust of the center's foundational research is looking at neuroplasticity, both at the neural and the network level. Dr. Rosenbaum, can you tell us a little bit? You mentioned Bruce Rosen and the Martinez Center. Can you tell us a little bit about how their work fits into this? You mentioned the human connectome scanner and some other tools that are available. Maybe you could talk to the specifics of some of that work and how MGH is particularly well suited to undertake this research.
Yeah, I mean, MGH is particularly well suited. There hasn't been a lot of neuroimaging beyond the study that Sharmin is describing. There are other studies in the planning stage. The Martinez Center's group has done neuroimaging of psychedelics in non-human primates and has an interest in it. I'm not aware. There's one study that's early in its development, looking at MDMA in a unique neuroimaging format where therapist and patient are in this scanner together. I'm not sure where that stands in enrollment now, but
hyperscanning.
It's a resource.
Hyperscanning, correct?
Hyperscanning study, right?
Can you talk a little? Sorry, can you just explain that a little bit more for people who aren't familiar? I understand that there's a handful of places in the world that are actually equipped to do this. What exactly are you doing? And
I'll defer to Sharmin for the explanations. I mean, I'm good at explaining to lay people, but not to people who really know what they're talking about.
I mean, hyperscanning. So hyperscanning can both refer to EEG as well as fMRI. And the idea is you're scanning two individuals at the same time. And so you're looking for instance, potential concordance in signal. And so, for instance, our colleague who is running that study of Vitaly Napadow has done it in patients with pain and their therapists, and shown that that there's a relationship between the alliance between the therapist and the patient and the concordance in signal in the brain when the subject is presented with pain and should invoke an empathetic response from the therapist. And so it's a great tool to look at interactions between people and how that might be represented in the brain to some degree. It's really dependent on the question that you're interested in. And so I think even in the MDMA study where they're using hyperscanning, they are hoping to look at alliance as well, because it's Vitaly Napadow who's doing that work. And that's what he's looked at before. So they want to look at alliance there as well.
And so what would the practical implications of that research potentially be in terms of how patients are treated, or is it unclear at this point?
I think that's unclear. I guess it'll depend on what's seen, because the patient is the one who gets MDMA. And then my understanding is that the thought is that maybe somehow the fact that the patient has received MDMA and the benefits of that in terms of connectedness might impact the alliance between therapist and patient, which may reveal itself in terms of neural concordance and signal.
And potential benefits and outcomes, I guess, as well, right?
Right. It might predict outcomes, who's more successful. I mean, even if you step outside of psychedelic-assisted psychotherapy, the reality is that we know from decades of research in psychotherapy, the alliance between the therapist and the patient makes a big difference for outcomes. That connection between therapist and patient is paramount.
Sharmin, could you imagine that there could be a study where the empathic connection between therapist and patient who receives MDMA and therapist and patient who doesn't receive MDMA could be compared to shed light on this issue about whether a patient on MDMA creates unique challenges for the therapist, as reflected in these allegations that occurred early in the phase 2 trials? Certainly, I never thought of it that way, but
unique challenges or unique opportunities? I don't know. I mean,
well, that it creates a unique connectivity that is something that is different than a very good traditional therapist-patient empathic connection.
Yeah, I mean, so I see where you're going. I mean, it could be interesting if, for instance, I don't know. But then you'd have to look at what is the likelihood that the therapist might be more inclined to
Right.
stretch boundaries or expand them in response to.
Reflecting on some of those comments at the Lycos AdCom, where they took those in couple of instances of boundary violations and sort of blamed it on the drug and not on the therapist. So I'm just curious whether the hyperscanning would shed light on that in some way, but just a far out thought.
Yeah, it would be a small signal to follow, right? That's for sure.
Dr. Rosenbaum, in terms of the focus on neuroplasticity, does this sort of indicate a leaning on the center's part towards this model of therapeutic benefit, that it's, what's happening is happening at the cellular or circuit level, or do you sort of leave room for the behavioral catalyst model? That there's been a lot of debate in psychedelics over the last few years as to, is this purely the neuroplasticity, or is there's this psychological aspect? How important is the role of the subjective experience? Obviously, a lot of companies now focusing in terms of drug development on Gen 2 and 3, where they're trying to take out the subjective experience for purpose of scalability and tolerability and safety and so on and so forth. Is it too early to know? Is there room for both of these? How do you see this sort of all playing out?
I mean, the challenge is that the word neuroplasticity is tossed around a lot, and it covers a lot of biological phenomena, and it's fairly universal. So, all our treatments that we know of in the mood disorder space enhance neuroplasticity, whether it's ECT or antidepressants, exercise.
Anything you do, right?
Almost any learning, what seems unique about some of the more rapid treatments like ketamine and potentially psychedelics is perhaps the robustness, and maybe maybe something about durability that remains to be seen. So I think of neuroplasticity as a necessary but not sufficient explanation of how these things work, because they all are, they're different in the onset of benefit and perhaps the durability of benefit. You see neuroplasticity in substances that you don't use as therapeutics, like cocaine. But it's an important area for study, because the rapid treatment psychedelics in particular do seem to robustly enhance neuroplasticity. Our colleague Steve Haggerty, who's part of the center, his lab has for a decade or more been focused on understanding neuroplasticity and creating humanized research models in the lab, like iPSC-derived neuronal models of human brains, including patients' mini brains, or organoids as they're called. And we're counting on that to help us try to understand differences among molecules that may be of interest as potential therapeutics or psychedelics.
And that work is super interesting. So here we're talking about using stem cells to create neurons that are from a patient, correct? And then create neural networks and synapses and these organoids, or mini brains as you refer to them, and test the compounds on how they impact the individual patient's neurons in a way that you can't do through any other method, correct? Is that right?
Right. How is one drug different from another? How are patients in mini brains or organoids different from non-patients in response to these molecules? So that would be the work of the Haggerty lab going forward.
And so this would allow a precision medicine approach, right? So finding the right drug for the right patient at the right time, at least theoretically.
Yeah, that's the goal. Precision medicine, for psychiatry, is talked about a lot.
Yeah.
Maybe with AI, we'll be able to take an individual's genome and exposome, their developmental history, their exposure to environmental stressors and toxins, and put that together in a model that aligns with likelihood to respond to one class of medicine or another. So I think we'll be able to have a model of individual risks for psychiatric disorders one day that combines genetics with history or exposure or the exposome. I'm not sure we have the therapeutic tools that would be so precise that they would make that model useful. I mean, right now, as with psychedelics, we seem to coming back to more psychopatholytics, more general, therapeutics rather than things that are precise. And where we've seen precision, it's usually been, my drug doesn't work for everybody, but it seems to work in this population defined by this biomarker. But it doesn't mean that that drug is better than the other drugs in that subgroup. It just means it doesn't work in other subgroups. There been some companies that develop drugs with the idea that it's precision medicine, but it only works in this subpopulation as opposed to the more generally effective agents that work more broadly. But I think it's a goal, and I can safely say now, given how old I am, it's probably not in my lifetime. But it is a goal, and I think someday, science will deliver on it.
Vital, our 12-month certificate in integrative psychedelic studies, is back for its fourth cohort, starting September the 17th, 2024. Vital is a process-oriented course with a deeply multidisciplinary curriculum that incorporates clinical, scientific, and relational domains alongside indigenous, shamanic, and transpersonal wisdom traditions. Vital is a vibrant community of students and alumni from around the world committed to merging powerful inner work with expanded professional scope of practice. Through lectures, study groups, webinars, elective modules, process papers, and online affinity groups, you'll have all the support you need to develop your own vision and model for lifelong growth in this exciting field. And new for this fourth round of Vital, we've introduced the option of choosing one of 5 specialization graduation pathways, which are regenerative business and leadership, depth and Jungian perspectives, somatics and trauma, spiritual emergence, or microdosing. Applications for Vital are open until August 23rd. So we invite you to apply early to improve your chances of being accepted into this global community of the next generation of psychedelic-informed practitioners. Head to vitalpsychedelictraining.com to learn more about this transformative journey, download our full course curriculum, and to apply. Best of luck, everyone.
I can safely say now, given how old I am, it's probably not in my lifetime. But it is a goal, and I think someday, science will deliver on it.
And how does this at all relate to the work that Dr. Haggerty is leading up with respect to the Schultz Center? Maybe one of you could talk a little bit about that.
So that's a great story in itself. But because when we started this center, I just happened to be chatting with Steve Haggerty and had no idea that since he was a pre-adolescent, he was fascinated with the world of ethnobotany and had read Plants of the Gods and as a 12 or 13-year-old. And he came out of the same department, Harvard Chemistry, as Schultz, and Schultz was sort of a hero to him. So he's always been fascinated by it. And so when we started the center, one of the projects that we imagined was something that he then called the Schultz Legacy Project, which was to explore plants that have a history or some ethnobotanical recording of human use that sounds psychedelic, like not necessarily like the psychedelics that are being studied today, but may have had other kinds of properties. So he was just eager to gather these plants, find out, fractionate them, find out what's in them, and run them through these models to see whether they might have these scaffolds anyway for therapeutic potential. So we were able to be given access to research greenhouses on the top of one of our research buildings, which were used for many years by a famous scientist named Fred Ossibel, looking for novel oncology drugs. He retired some years ago. It's been laying fallow. So the center and Steve and his team have been able to acquire that and already moved some plants into it. And the goal is to raise sufficient funds to really bring this massive greenhouse, lab space, and office space, into the modern age. It's a little bit outdated, but there are plants growing there, and that's the goal, to explore these unexplored plants for a novel leads for therapeutics.
And so these are all plants that Schultz would have identified on his various trips to South America?
Some of them are Schultz, and some of them are just Haggerty. And, from his, reading, exploration, there are about 15 plants up there now, or he has 50 that he's interested in. And, it's certainly a fun project, and it could be transformative. You just never know. I mean, when you have this history of human use in plants, they may not be optimized as drugs, but they could be signals. Maybe somebody chewed these plants or made teas out of them, but they're really not optimized as drugs. So you find out what these molecules are, you study them, or you use medicinal chemistry to make them more drug-like, and perhaps you come up with compounds that will allow you to be precise for some particular vulnerability or symptom or disorder.
Anything that looks particularly promising at this point, or is it just too early?
Well, certainly it's too early. And if it were, Steve would not let me tell you.
Fair enough. Well, it sounds fascinating. So I think we've very briefly touched upon 3 of the 4 program areas. So the chemical neurobiology lab, the clinical and translational research, the Martino Center. Obviously, MGH has a big educational function, Harvard Medical School's main teaching hospital. Can you talk about how education and training fits into the center and what type of work you're doing there in terms of your focus?
Yeah, there are a number of components. So our Department of Psychiatry has something called the Psychiatry Academy that does a lot of teaching of colleagues or other mental health professionals and so forth. Thousands of people come through to Boston or online for academy courses. And after starting the center, we started doing 2 courses. One is a 3-day course on psychedelic medicine that our colleague Franklin King directs. That I think we've had 2 years of that. About 400 or 500 people attend, so it's a good sized course. And then we have an evening seminar that's attached to our annual psychopharmacology course. It gets about 1,000 people every year, and some subgroup of that will elect that as an evening seminar. So we do those. There's been some teaching efforts, or some exposure efforts, I should say, for students both at Mass General and the Harvard system to sort of learn more, observe more in this space. And we were fortunate to be awarded a philanthropic gift from the Thai Foundation that has allowed 6 or 7 fellows to have 2 to 5 years of research support in the psychedelic arena. So that's another example of that. So there is an educational arm and that's part of the center as well.
And it's a significant demand, I take it, for this type of training, given the
a lot of interest. Yeah. There's a lot of interest. It's particularly among the young people. I mean, the trainees are very interested in being part of the renaissance in psychedelic medicine.
Dr. Ghaznavi, what's next for the center in terms of what the next several years hold? What are you particularly excited about in terms of research projects or areas of focus?
I think we're excited to get some of these studies and projects off the ground, see what information they yield, and all the interesting potential research pathways from there. So, because these studies are so hard to do, any one of them have a lot of components. So, for instance, actually looking at markers of neuroplasticity in humans as opposed to just the preclinical. So I think that's going to be really exciting, especially given the mission of the center. And in some ways, we're uniquely poised to do it because we have collaborators at the Martino Center who use the methods and also developed the ways of analyzing that data to look at some of those markers. I think it'll be really exciting to see how we're beginning to explore what can psychedelics be paired with to potentially improve outcomes or durability. But I think, we're kind of open and curious to see where the data leads us in terms of next questions.
I have an interesting anecdote that I probably shouldn't tell, but after hearing Goldolan's work on critical periods and social learning, and whether you can really reopen critical periods that are closed through development. I had this funny idea. I don't know if I mentioned to you, Sharmin, but maybe I did, which is that wouldn't it be great, again, if somebody took up golf late in life, and it's like learning a language. If you don't start when you're young, your swing always has an accent. So I had this idea that, why don't we open a series of golf clinics where, psychedelics will reopen that critical period for learning golf swing, train and live your dream. So I was actually on a panel with Robin, and I was giving him a ride back to the airport. So as a joke, I told him that. And about a month or two ago, I saw that there was and I don't know if they're connected or not, but that there was somebody who was starting a business with that idea, and Robin was one of the advisors.
That is the most unusual application of psychedelics I've come across to date.
But it could be very lucrative.
Suppose so. What about prevention? So Dr. Ghaznavi, I've heard you talk a little bit about prevention potentially through the use of psychedelics. Can you expand on that a little bit and what that could look like and how that might work?
So, let's take the case example of rumination. So we know, for instance, the data is there that rumination can lead to relapses in depression. And so it's a good predictor of whether or not someone will go on to have another major depressive episode. So you might imagine that if we're actually able to impact rumination and decrease the tendency to ruminate in folks long term, right? So there've been lots of intervention studies trying to look at rumination, but they look like 6 weeks out or 12 weeks out. But a real tendency to ruminate is something that's sort of more trait-like and characteristic of the person. And to see whether that really changes, you need to follow people for a lot longer, as well as to see if they relapse. But if we could intervene in a way that's meaningful and change people's tendency to enter into those cycles, then that might be a way to prevent people from having the next major depressive episode. So that's one potential way for there to be an intervention, but and that's aimed at prevention. But I think it's sort of seated in this idea of like neuroplasticity, right? If people can learn new patterns, then the thought is that we could prevent them from getting ill, because part of what's putting them at risk for getting ill is the patterns that they've gotten used to engaging in and is sort of entrenched in. The reality is, like, people who have a family history of major depression, we know that they're at risk of having of developing major depression themselves. We also know certain behaviors, like internalizing behaviors, as we talk about, where people are, tend to bring the blame in on themselves or what have you, predispose people to having a depressive episode. And part of how that happens, one of the moderating variables is thought to be rumination. So there again, we might even actually be able to prevent people who are at pretty high risk of developing it from having a depressive episode. It'd be great if we could stop suffering in its tracks.
Yeah.
Before it ever happens.
Absolutely. We're obviously still very much in our infancy in understanding these compounds and how they work and what they're good for. What do each of you expect over the next 5 to 10 years? Do you foresee any major breakthroughs in terms of where we're at and where the science is leading?
I mean, there'll be new compounds beyond the ones that, the old psychedelics that everybody is familiar with that have been either reformulated or, IP developed around so they can be commercialized. There'll be novel therapeutic molecules. I mean, I think potentially there's an infinite number of them that, and it's a matter of selecting them and deciding what indication. But I think once the first or second movers do the heavy lifting of creating an infrastructure and payment structure for psychedelic procedures, I think they'll be a big part of the future of healthcare, certainly for psychiatric, potentially for neurologic and neurodegenerative and anti-inflammatory and other indications in the future. So I think the long term is, I think, bright. I just think it's going to be a very fraught short term as we try to figure out how to bring to market, scale up, and decide who gets what.
And how big do you see that challenge as? It's obviously something that's become a real focus for a number of companies in the space. I think, 5 years ago, people weren't really talking about the infrastructure and scaling up and training therapists and so on and so forth to the degree that they are now. I mean, how long of a path are we looking at to get to where we need to be, given the number of people who could potentially benefit from various compounds for various indications?
I mean, the backlog of demand, I think, is going to be very high. That'll create problems in and of itself. I think of the VA. I sometimes wonder whether that was partly behind the VA clinicians' hesitancy about approval, is that what will that do to the VA budget if they have to ramp up the infrastructure for all the veterans waiting for these treatments? What will happen to their budgets?
Yeah.
So I think it's a big challenge. I mean, it will be solved, but not easily and not soon. Yeah, but you saw a little hint of it with Spravato, which had a very slow uptake in the beginning because of the infrastructure burden and so forth, and now it's doing better in terms of volume. So these are obstacles that can be overcome, but I don't know. I don't think it will be easy or fast. So I think it'll be still years before psychedelics are available and or accessible to many of the patients that could benefit from them.
So we're likely to see a reality where we have the first one or two or however many drugs approved, but really limited access in terms of patient population at that point.
And then there'll be second, third movers. And we've seen this with other drugs, like the fifth or sixth SSRI still became a multi-billion-dollar market. And then the winner was the one that had very minor, or the winners tend to be those with very minor advantages, whether it's kinetic, short, faster onset, shorter duration, or maybe more durability, or a gentler or more easily tolerated experience or something. There'll be some differentiator that where those that come later will be able to have a large share of the market as well. Won't be just the first mover.
Yeah. Dr. Ghaznavi, what do you see for the next 5-10 years? What breakthroughs do you potentially expect?
Well, I'm hoping that in addition to, research in psychedelics takes two different formats. One is looking for new indications and just trying it on a different, a new population. And the other research that, for instance, the center is really trying to make progress on is trying to understand how these compounds work. And I think it's not because, that's necessarily going to, lead to a better understanding immediately of how these compounds work, but they could open up avenues for pursuing other treatment as well. So, for instance, understanding the time windows of, where plasticity is optimal can help us decide when to pair treatment with, when to pair therapy or neuromodulation with a psychedelic. And my hope is that the next, 5 to 10 years, we make some real progress towards understanding that to really be able to capitalize on something that seems to be unique about psychedelics in terms of their ability to increase the capacity for plasticity.
Right. And so what you just referred to for not just necessarily facilitating psychotherapy, but facilitating or enhancing other interventions like TMS or other forms of psychiatric intervention will be enhanced or synergized by psychedelic molecules.
We still have a few minutes left. So, Dr. Rosenbaum, I wanted to ask you about the recent advisory committee meeting and decision in voting against a finding that Lykos had established the effectiveness of MDMA for PTSD and that the benefits outweighed the risks. They identified a number of perceived shortcomings, functional unblinding, potential expectancy bias, lack of safety data, lack of reporting at adverse events. I think you've been quite critical of how the hearing was conducted and in the vote of the advisory committee. I was wondering if you could comment on what you think they got wrong and where do we go from here? August 10th is, I think, when we're expecting a decision on the the new drug
So
application.
you probably saw one harsh statement. I don't know that I've been quite critical.
Maybe that was the one I read.
I did see a reporter say something that I don't remember saying that seemed pretty harsh. I think there was something in that day. I mean, I was there from morning to evening. There's something there for everyone. You know, the advocates and the haters. I mean, there was plenty of fodder to. My main feeling is that the FDA presented a very balanced overview of the data, the packet, and the challenges. I thought there were some things where the members of the advisory committee sort of were just ignored the FDA's requests for what they wanted them to focus on. Said some crazy things like not being able to say the name of the drug right. If you're the chairman, you should be able to do that. Yeah. The idea that if you get your PTSD treated, you want to go home and use alcohol or cocaine was crazy things to say. To say, I've never seen an effect size so large, but gee, I can't get over this functional unblind. So there were a lot of things that the committee members said that made no sense. There was a committee member that made a passionate argument to reject the drug, and I think led a lot of the panel to that vote and then voted for it. And so there are a lot of things I couldn't understand around the committee. For me, the issue was the FDA basically said, we are confronting this issue of functional unblinding. This is an important issue for us to deal with because there are an array of treatments coming along that will raise the same issue, and sort of turned to the committee to discuss it, and they didn't or didn't know how to, except to say, gee, it's bad. And yet we know that if there were a drug that was universally effective, everybody who took it got better, but the only problem was there was an unmistakable signal that you're on it. Let's say your nose tingled or something. They wouldn't deny it. They'd figure out a way to set criteria to determine whether it's approvable. And they basically throughout the day threw out a bunch of these things, like the effect size. You know, if the efficacy is high enough that you factor in functional blinding, it still looks effective. There's a plausible mechanism of action. Its effects seem durable, distinct from the natural course of the illness. Whether there's a way to make it safe, either because it is safe or you have a REMS program that would keep it safe. Then you have blinded external raters who are changed at every, so that and they're trained not to get signals from the patient of their belief about what they're on. And finally, the dry weight of all that we know from human experience, whether it's testimonials and others, you can take those, whatever that was, 6 criteria, and put them into a bucket and say, these are the criteria around which we're going to evaluate whether we think this treatment is safe and effective. And I thought they sort of, some of those elements were present, others were present but not optimal. But I don't think it's a challenge going forward for psychedelics. I think that what MDMA faced was sort of unique to their history and some of the sort of counter detailing or negative part of the hype cycle that hit them just before they came through. I think the functional unblinding thing is just like, what are our criteria? We're going to have to deal with drugs that people know they're on, but most of us believe can be helpful. And the FDA, I thought, made that clear, but the advisory committee didn't seem to be all that sophisticated about the issue. And then there were the issues about the therapy, and we could go on about that. I mean, whether this was a quote unquote experimental therapy, as one of the AdCom members called it, or whether I kind of called it a generic therapy. There was nothing in that therapy that a therapist wouldn't understand or know how to do with a patient. They harkened back to some of the early theoretical underpinnings of the therapy, going back to Groth and the inner healing stuff. It's a little new agey, but it's irrelevant. I mean, I would have preferred that they had taken a course of development where they used MDMA with a number of different evidence-based therapies, like do it with cognitive processing therapy or prolonged exposure or something else, and done it in 3 different types of therapy. So you can really say this is a therapy enhancer, rather than this idea of, is this a unique therapy and the FDA doesn't approve therapies, and that got confusing. All that said, I mean, I think most people who have been involved in treating or observing treatment with MDMA and therapy in patients with PTSD think it's a therapy enhancer and it works. And given the number of people who suffer and the need for new treatment, nobody should be happy that it failed.
So where do you think we go from here? I understand that something like 33% of those instances where the AdCom votes against a recommendation, drug still gets approved. I think Biogen had a major Alzheimer's drug that got a pretty negative hearing from the AdCom and then was approved. What are your expectations for what may happen?
Well, I turned to Yogi Berra on this one. Prediction is particularly hard, especially about the future. But yes, they can. I think they want to, but I think it's a tough vote. I think there were gaps in the data that would require effort on the part of the company to remedy. So it's possible they'll be given a relatively challenging roadmap to approval, but I think they'll still be given some roadmap to approval. Whether they get approval just on an override of the committee vote, I don't know. I mean, some people say it's a 50-50 chance, but I don't know how to call it.
Speaking of drug development, you're also in the drug development business. As I understand, you're co-founder of 3 psychedelics companies, Sensorium, Entheos, and Psi Therapeutics. Can you tell us a little bit about what you're focused on there? And
so only one of them. Psi Therapeutics is a traditional drug discovery company based on targets and a DNA encoded library of novel molecules that bind to those targets, and really has nothing to do with psychedelics whatsoever. He's looking at things like pain and depression and Parkinson's disease and Alzheimer's and that sort of stuff. So it's not psychedelic at all. Sensorium was founded in part with the same idea that there's ethnobotanical history that can be pulled into a database and with AI to explore leads for novel treatments, but it's specifically non-psychedelic. So it's looking at things like epilepsy and anxiety and so forth. The last company is a very early startup that is its goal really it was to when we started the Schultz Legacy Project. My fantasy was philanthropists would be falling over themselves to fund this. I wasn't right, and so we had to figure out how to do this. So we by chance engaged with an entrepreneur who has a successful startup and was interested in consciousness and psychedelics. So started this company called Entheos Labs, which is in a second seed round. And its raises go to supporting the Haggerty Lab in large measure, but as part of the effort to create value, has actually identified a psychedelic lead, which we think is unique. But anyway, that really is something we hope to advance and use any success with that to fund the research at Mass General. Is a collaboration agreement with MGH. MGH actually owns a little bit of the equity in the company. So it really is sort of a startup with close ties to an academic effort.
Okay, all very exciting. I think that's it in terms of my questions. Anything we haven't covered that you wanted to talk about?
Sharmin, anything you want to talk about?
I mean, one thought I had about something earlier that you'd asked, Chris, you'd sort of said, you kind of talked about the sort of dichotomy of neuroplasticity versus like the experience or the subjective experience. And I think sometimes it's a false dichotomy that people draw because, it's almost a little dualist in the sense that, somehow subjective experience is not being realized in the brain or having an impact on the brain. And it might be that subjective experience also contributes to the plastic potential. We don't know. I think that's an open question. And so, sometimes people see the discussion about neuroplasticity as being reductionist or just focused on neurons, but, human experience realizes itself in brain activity.
Yeah, there's neurocorrelate of anything that's going on, obviously, right?
Right.
Yeah.
Exactly. And so I think sometimes that they're not in any way as like in opposition of each other or downplaying one component of what the psychedelic experience might be like. It's really about understanding.
Not either or.
It's not either or, right?
Yeah, although it seems to be talked about a lot that way for some reason.
Yeah, I think it's a false dichotomy. It's like people, it goes back to our dualist idea that somehow like things are, either you're about neuroscience or you're about the patient experience. And, as somebody who's both a clinician and a neuroscientist, that division seems a little bit, false.
Yeah.
In 1934, the founder of Mass General Psychiatry said mind and brain are one, that
visionary
function is organic and so forth. Yeah. So he was a neuropathologist, which is an unusual choice for a chair of a psychiatry department, but he said that sort of set the course for us.
And so for those who are interested in following your work or supporting your work, what's the best way to follow you? Where can they find more information? I'll include the link, obviously, to the webpage in the show notes. But
there is a webpage, and we can be reached through that. Yeah, happy to hear from people who are interested.
Super. Well, thanks so much for the very interesting conversation. I appreciate your time today.
Thank you. Thank you for time.
Thank you.
And there you have it. I hope everyone enjoyed this episode. If you want to check out the Center for the Neuroscience of Psychedelics, you can find a link in the show notes. And if you haven't subscribed to the podcast, I would encourage you to do so wherever you get your podcasts. You may want to consider leaving a review, which helps get the word out. And please be sure to follow Psychedelics Today on social media. Questions or comments can be directed to info@psychedelicstoday.com. I have some other interesting guests in the works, so we'll be back in the near future. Until next time, thank you for listening.